there is a discussion going on about to utilize urodynamic, invasive urodynamic studies preoperatively in so-called complicated and uncomplicated patients. So what is your opinion about complicated and uncomplicated classification? And what is the percentage actually of the so-called uncomplicated or index patients in your real practice?
Yeah, there's a lot of well-publicized studies, and I think specifically we're referring to the value trial, which was really designed to determine like the impact of preoperative urodynamics on a set of totally uncomplicated stress incontinence patients. Although this is a very well-designed, multi-center trial, these patients underwent office evaluation of their stress incontinence, randomized to patients who underwent multi-channel urodynamics. And interestingly enough, the outcome was only treatment success by patient-reported outcomes. It wasn't actually an objective measure of outcomes. Now, the trial certainly transformed some of our thought processes regarding an index patient, and it's supported by the guidelines because it's cost-effective in many instances. But let me reiterate, these patients in this trial were not the patients that we typically see in our clinics. They were completely uncomplicated stress incontinence patients, which is rare. So when we're really discussing value, it's an equation of high quality and low cost, but there's little value for women who fail to get appropriate diagnosis for a pelvic floor disorder and undergo subsequent invasive treatments, which would not be successful for cure and may actually exacerbate their condition and lead to further interventions. So I think our guidelines are actually clear that judicious use of urodynamics is appropriate and should be employed when there is not absolute clarity in the diagnosis prior to invasive treatments, or for patient counseling to help them understand that pathway prior to invasive treatments. The optimal approach is shared decision-making. It's personalized medicine where we tailor the diagnostics and treatments, not just to the condition, but to the patient desired outcomes.
Exactly. I mean, the urodynamic studies for me, without any question, are the gold standard evaluation methods for the lower urinary tract function and dysfunction. And interestingly, the index patients actually are the minority of our patients. Even in the value study, they were about 30%. But in centers like ours, where we are working in the referral centers, this ratio falls down to even 3%. So there are many publications. I just looked also to my database, and it looks certainly below 5%. So the ratio of uncomplicated or index patients are very low. So the real patient bulk that we are facing is complicated patients, no question. How would you define a complicated patient? What is a complicated patient in your practice, Melissa?
Yes, certainly ones that have undergone prior surgical interventions, certainly patients who had other comorbid conditions, not just urgency incontinence, but patients with prolapse, either with or without incontinence. Those are also patients that benefit tremendously from having a preoperative multi-channel urodynamic study. I need to understand more about what's going to happen after we do a prolapse repair. Do they have a higher risk of developing incontinence? I don't typically employ concomitant stress incontinence procedures unless I either demonstrate on urodynamics or they have a pre-existing known stress incontinence component. I have many patients, because they've had prior interventions, who may also have some difficulty with bladder emptying, and it is critically important that we understand detrusor underactivity in that population prior to embarking on any further surgical interventions.
And I think invasive urodynamic studies are the methods that will show us the pathophysiological mechanism behind the symptoms of the lower urinary tract dysfunction.
The sophisticated and granular information that it provides is just the gold standard for diagnostic testing. There's no ways around any other metric that we have today that allows that.
The problem that I see with the urodynamic studies all over the world is the technical quality of the urodynamic studies. So even in published studies, there are so many, errors in these studies, which clearly show us that we need to increase the education and the quality of our urodynamic studies. And I would like to just promote the ICS project about the urodynamic traces here. In the urodynamics committee of the ICS, we are inviting all the traces from our members just to evaluate them and to give them a feedback. This is, I think, a very helpful tool in the education and in the improvement of our urodynamic studies all over the world. Because the urodynamic studies will only help us if they are done in a proper way, in a standard way, according to the ICS standardization.
I love that concept of doing some centralized feedback for the actual providers. With all procedures, there's certainly a degree of operator dependence. And what we're really trying to do is replicate that patient's daily symptoms to the findings. So this can be a very iterative procedure, one that requires our presence, one that requires feedback from the participants as well.